Genetic testing of embryos, is it right for you? There are pros and cons of pre-implantation genetic screening of embryos, and you've got to know if it's right for you or not. It's a big decision, and today we're going to review pre-implantation genetic screening of embryos for aneuploidy. We're going to go over the pros and cons, the risks and benefits, and I'm going to leave you with questions to ask your doctor to help you figure out if it's right for you. Let's get started. I'm Dr. Lora Shahine. I'm a double board certified OBGYN and reproductive endocrinologist, helping people build families and decide whether or not to do genetic screening of their embryos for over 20 years. I have really seen a dramatic change in the use of this technology over my own career. And I think it's a very important decision to come together with you and your doctor. Not everybody needs to do this screening, even though it sort of feels like everyone is. I love educating. If this is your first time finding this channel, welcome. Be sure and subscribe so you get my weekly videos all about reproductive health. And if you're coming back, welcome back. I am so happy you're here to learn. There are two other ways to stay in touch and get more education. Number one is my weekly podcast, the Baby or Bust Fertility Podcast. You can listen anywhere you listen to podcasts. And my weekly newsletter, there's a link in the description. You get fertility news, you get educational content, and you get recommendations for products and books that I love. Now, today we're going to be talking about a very important decision to make. If you have decided to do IVF, a big decision is whether or not to screen your embryos for pre-implantation genetic screening. Not everyone needs to use this technology, but it can feel like everyone is. And you need the tools to decide what is right for you. Science and IVF are incredible. Over 12 million babies have been born with this technology worldwide since the first IVF baby, Louise Joy Brown, in 1978. But this genetic screening of embryos is relatively new compared to just the general technology of IVF, and it's changed drastically over the years. Today, we're going to learn all about it, and you'll be able to ask your doctor questions and figure out if this choice is right for you. We're going to go over 5 main topics today. Topic number 1, definition. There's many different types of genetic screening of embryos or genetic screening of people, and you just got to know exactly what we're talking about. Topic number 2, you got to know what's happening. If you decide to do genetic screening of your embryos, what is going on in the lab? Topic number 3, who should do this screening? Who should do PGT-A, pre-implantation genetic testing of embryos for aneuploidy? We're going to review evidence. Topic number 4, I'm going to tell you how I counsel my patients and how I use my 20 years of experience interpreting information, talking to patients about their personal situation. I'm going to tell you what I tell my own patients. Topic number 5, common misconceptions when it comes to genetic screening of embryos. Now, stick around to the end of the video where I give you really important questions to ask your doctor to help you make the right decision for you. Topic number 1, definitions. We've got to know what we're talking about. This video is focused on PGT-A, pre-implantation genetic testing of embryos for aneuploidy. Aneuploidy is chromosome content. Every cell in our body and every cell in the embryo should have 2 copies of each of the chromosomes. 1 copy comes from the egg, 1 copy comes from the sperm, and they should line up. So you're looking for embryos that have incorrect chromosome content, an extra number 7 chromosome, or missing a number 2 chromosome, or big portions of DNA that are missing. So you're looking for chromosome content, PGT-A for aneuploidy. Now, there are other things that people will test for in their embryos. There's PGT-M and PGT-SR. PGT-M is looking for monogenic or single gene mutations within the embryo. So this is something that parents can pass on to children, meaning specific mutations that lead to specific diseases. Things like cystic fibrosis, muscular dystrophy, sickle cell disease, spinal muscular atrophy. So anytime I'm seeing a patient that's planning to do IVF, or honestly, I offer this at my very first new patient visit, I say, hey, we should offer you carrier screening. What that means is you're looking at the people that are getting pregnant to see if they carry mutations that they could pass on to their child that could cause disease. So someone could have a mutation for cystic fibrosis, they don't have cystic fibrosis. Nobody in their family has it, but they have that mutation. If they happen to partner with another person that has that exact same mutation, they have a 25% chance of having a child that's affected. And so it's rare for people to carry the same mutations, but I'm often seeing people that's the whole reason that they're coming to see me, because they had a child with a genetic disease and they are doing IVF in order to screen for embryos to not pass it on again. It's a lot of information. I have a whole video here just about kind of the different types of genetic screening of embryos. So you can go into depth with that video, but that's PGT-M, specific genetic mutations. And you have to know what you're looking for. You can't screen every single embryo for chromosome balance, aneuploidy, and PGT-M unless you know what you're looking for. So you got to test the people before they create the embryos to know if you have to look for it. So most people that are doing genetic screening of embryos are doing PGT-A, not PGT-M. The other one is PGT-SR. I know this is confusing, but it's just so important. You might even see this on your educational videos for IVF or your consent forms. You got to know what we're talking about. PGT-SR is looking for structural rearrangement of chromosomes within embryos. And so you have to know whether to look for this or not. And people who are using this type of check know that they carry a balanced translocation. This is something that I look for in patients who have recurrent miscarriage. I do a karyotype or a blood test looking at chromosome arrangements in the people that are getting pregnant. And if someone has a balanced translocation, we will offer them PGT-SR for structural rearrangement. Just like PGT-M, most people that are doing genetic screening on their embryos are not doing PGT-SR. So the rest of the video, I am talking about pre-implantation genetic testing for aneuploidy. Topic number 2, how does this testing work? So if someone says, yes, I want to do PGTA or pre-implantation genetic testing on my embryos, the way it works is you do an egg retrieval, you get eggs, you got sperm, you combine the eggs and sperm in the lab, and it takes about a week, like 5, 6, sometimes 7 days for a single egg and a single sperm to become a mature embryo that's called a blastocyst. A blastocyst is about 100 to 200 cells, and it's just starting to turn into 2 separate parts of the embryo, an inner cell mass that will eventually be the fetal cells, and a trophectoderm surrounding the embryo that's eventually going to be the placenta. And so if you're doing PGT-A, you're testing your embryos. Once the embryo is a blastocyst, the embryologist will biopsy about 5 or 10 cells away from the trophectoderm. So you have to have a fully formed blastocyst, and you biopsy those cells. We freeze the embryos. The embryos stay in my lab in Seattle, and the cells that we're testing, we ship to a specialty lab to do the genetic testing, and they give us a report back later. So if you are doing PGTA, you cannot do a fresh embryo transfer. You are collecting cells, freezing the embryo, and once you have information back and you know that you have a euploid, that means balanced chromosomes within the embryo. If you have a euploid embryo, then you can do a frozen embryo transfer later. So I just want to make sure you've got the basics. Topic number 3. What does the evidence say? Should everyone do PGTA or genetic screening on their embryos? What does the research say? So it makes logical sense. If chromosome imbalance is one of the main reasons that embryos don't implant, it's the #1 cause of first trimester miscarriage, then it makes so much sense to do this testing. You should see improved outcomes. You should see decreased miscarriage. You should see increased success with embryo transfers. And it makes logical sense. If you've got this tool, you want to use this tool. And so that makes a ton of sense. But what does the evidence actually show? I'm going to share 4 studies kind of through the years that really are trying to answer this question. I'll go through each one, so bear with me, but I think these make really important points. Because the use of this technology has increased dramatically through the years. The SART, or Society of Assisted Reproductive Technology, that gathers reports from some clinics around the United States has said that the use of PGTA or genetic screening of embryos has increased dramatically. In 2014, 14% of all IVF cycles were doing this genetic screening on embryos. And just 5 years later, in 2019, it was 44%. That's a big increase. And I bet it's even more today. So let's review these studies. There was an initial pilot study done in 2012 that was very promising for the outcomes of PGT-A testing. So in this study, there were 112 good prognosis patients. They were less than 35 years old. The indication for IVF was either male factor fertility or tubal disease, and it was their first IVF cycle. And these 112 patients were randomized to either PGT-A screening of their embryos or not. If they did not have PGT-A to screen their embryos, the embryos were selected solely on morphology, or what the embryo looks like under the microscope. So fragmented cells, even distribution of cells, just really like a beauty contest. Embryos look great. Those are the ones we're going to choose to transfer. Ongoing pregnancy rate was 69.1% in the PGTA group versus 41.7% in the non-PGTA group. And this was statistically significant. The p-value was 0.009. And if a p-value in a study is less than 0.5, it's considered statistically significant. Of note, there was no difference in miscarriage between the two groups. And you have to realize this is a pretty small number of patients to make a really large decision on a technology. But the authors emphasized that they had this high success rate with a single embryo transfer in the PGTA group, and that was a real benefit of this technology. IVF for the longest time has had a reputation for causing twins, triplets, and the risks that are associated with multiple gestation. And so one of the key points of this pilot and really important study in 2012 was a wake-up call to say, hey, if we use PGTA as a way to select for embryos, we can decrease the risk of multiples. There may be lower incentive to transfer more than one embryo. A follow-up study published a few years later was another randomized controlled trial with more patients. It was 175 patients included in this study. Mean age of the eggs was 35 years old, and the patients were randomized to PGTA testing or not. The patients that had PGTA testing transferred a single euploid blast, and the patients that did not transferred two morphologically normal blastocysts. The ongoing pregnancy rate was 60.7% in the patients that transferred a single euploid or tested blastocyst versus 65.1% in the patients that transferred two unscreened blastocysts. But the chance of multiples or twins was dramatically different. In the patients that transferred two blastocysts, the twin rate was 53%. And there were no multiples or twins in the single embryo or screened embryo transfer group. So there was a similar ongoing outcome or pregnancy rate, even if it was slightly higher in the non-PGTA group, but the chance of multiples was dramatically lower when you transfer a single embryo. An important point about both of these studies is that they're only reporting outcomes for people that actually had an embryo transfer. And that's really important because a lot of people that are going through the shots and going through the egg retrieval, sometimes people don't have embryos. Either all the embryos are abnormal or embryos stop developing before they become blastocysts, whether you get the screening or not. And if you're really trying to counsel patients about what they should do or what their outcomes could be, you should include intention to treat when you're randomizing groups, meaning no matter what happens after they're randomized, they're either successful or not. And you're including people that didn't get any eggs at their egg retrieval. You're including people that didn't have any fertilization after the egg retrieval, or they didn't have any blastocysts to screen or test, because that is reality. So when you're comparing embryo transfer, it's important. You're getting data, you're seeing outcomes, but if you're really trying to counsel somebody, you might want to include intention to treat analysis as a way to say, hey, this is a realistic picture of what is going on and how I might be able to counsel you. Now, I got two more studies to share with you. Bear with me. I just think it's really important. There are two large multi-center randomized controlled trials that came out later than these first two studies, and I really want to share them with you. In 2019, there's a randomized controlled trial that was published. It was from 9 centers and 34 clinics in the United States that combined data. Patients that were excluded from this randomized controlled trial of PGTA or not were if they were over the age of 40, they have a history of recurrent miscarriage, and if they have a history of multiple IVF failures. This included 661 patients. They were aged 25 to 40, and they had 2 blastocysts available. And either these blastocysts were screened with PGTA screening or not. A future frozen embryo transfer cycle did not show a difference in outcomes about whether they got PGTA or not. The ongoing pregnancy rate per embryo transfer was 50% with the PGTA group and 46% in the non-PGTA group. This was actually similar. There was not a difference if you included intention to treat analysis. Remember how I was talking about how important that was? So if you included everyone, whether they got an embryo transfer or not, in the PGTA group, the ongoing pregnancy rate was 41.8% versus 43.5% in the non-PGTA group. Of interest, after analysis and kind of looking back, showed the percentage of abnormal embryos based on age. I think this is interesting because it helps me counsel my patients. In the group of women that were a little bit older, so egg age 35 to 40, the ongoing pregnancy rate was 51% if they did chromosomal screening of their embryos versus 37% if they didn't. So I think that's pretty interesting. It's noteworthy to realize, and there's kind of always interesting things when you really delve into studies, the percentage of abnormal embryos really changed based on egg age. 52% of the embryos were abnormal if the egg age was less than 35, and 64.5% of the embryos were abnormal if the egg age was between 35 and 40. Okay, the last study I'm going to share with you was published in 2021. Thanks for sticking with me. I just think this is such important information. It's a randomized controlled trial from China with over 1,200 women included. Egg age was from age 20 to 37, and everyone had 3 high-quality blastocysts to be included. Either they got PGTA testing of the embryos or just conventional morphology, and they underwent 3 sequential embryo transfers with a single embryo transfer, all frozen embryo transfer cycles. The conclusions show live birth rate, which is really important when you're trying to counsel patients. The live birth rate for the group that was randomized for PGTA was cumulatively 77.2% versus 81.8% in the morphologically selected group. Now, miscarriage rate was lower in the PGTA group. It was 8% in the PGTA group versus 12.6% in the non-PGTA group. What's interesting is even though the miscarriage rate was lower in the patients that got the PGTA testing, the cumulative live birth rate was honestly similar, and there was no decreased time to live birth for patients who did the PGTA testing or not. So sometimes people say, oh, well, is it going to make me have a baby sooner if I do the PGTA testing? Because you're sort of hopefully decreasing the number of transfers that it takes to have a baby. In this particular study, that was not the case. And remember, these patients were all 37 years old or younger. The eggs were 37 years old or younger. So if you ask the question, should everyone do PGTA testing? You should really talk to patients about, hey, some of the studies are really showing, depending on who you are, and indication and randomization and all these things, that sometimes it really doesn't change the overall chances you're going to have a baby. So I want to make one more point, share one more piece of data. SART, or this Society of Assisted Reproductive Technology, where they report outcomes and whether people do PGTA or not, released information based on age, live birth rates, and miscarriage rate based on whether someone did PGTA or not. I want to share one more research sort of data collection that really helps kind of drive a point home. SART, or the Society of Assisted Reproductive Technology, released this information: implantation rate or pregnancy rate and miscarriage rate divided by age on whether people do PGTA or not. So I've got a table here. I want to show you the table. It's summary from SART, the Society of Assisted Reproductive Technology, and it's basically showing that as eggs age, there's a higher implantation or pregnancy rate if you do PGTA and a lower miscarriage rate. And this table is really helpful kind of driving that point home. And it's really important for counseling patients. So if you look at the table, you see age, And then you see implantation rate with or without PGTA testing and miscarriage rate with or without PGTA testing. So if someone is 35 years old and they do an IVF cycle, if they do PGTA testing, their implantation rate was 62.7%, and it was 54% if they didn't do PGTA testing. The same age group, if they did this testing, miscarriage rate was 11.2%, and it was higher miscarriage rate, 15.4%, if they did not do the PGTA testing. Okay. And then if you look at, let's say, age 38 to 40, same table. If someone does PGTA testing, their implantation rate is 59.5% versus 30% if they don't do the PGTA testing. And their miscarriage rate is 13.6% if they screen the embryos versus 27.7% if they don't screen the embryos. So you see, as the eggs age, PGTA testing can impact implantation or pregnancy rate and miscarriage rate. And that impact is more dramatic the older the eggs are. So I just want you to have that information because it really helps me counsel patients. And that's leading into topic number 4. How do I talk to my own patients about PGTA testing? I really have to make sure that you know that you need to talk to your doctor about your personal situation. But in general, this is how I kind of talk to my patients about it. When I'm talking about IVF in general, I'm like, hey, we have to make 2 decisions. You know, you've already decided to do IVF. That's a big decision. When we are making the next decisions is, how are you going to fertilize the eggs? And I have a whole video here on ICSI or not, intracytoplasmic sperm injection or not. Okay, so that's an important question. And the second important question is, are you going to do PGTA testing or not? And the way I introduce it is, hey, not everyone needs to do PGTA testing. I've been practicing for over 20 years, and I remember when we didn't have this testing available to us. I think I have seen a dramatic change in practice, and more people are opting for it. But I think there's pros and cons. Not every test is perfect. I think of PGTA testing as an amazing embryo selection tool. So if someone has a lot of embryos, they've got a chance of a lot of eggs, a lot of embryos, it's an amazing way to narrow down and to select for embryos that have a higher implantation rate. And I think it makes a lot of sense as the eggs age. So the tipping point is really age 38 or older. I'm really thinking about, gosh, the majority of the embryos are going to be abnormal when the eggs are 38 years or older. So that's a group of patients that I'm strongly considering PGTA testing. And I also do talk to patients about it who have had recurrent miscarriages. Studies vary and outcomes vary, but if someone knows that they're having miscarriages because of aneuploidy, because of chromosome imbalance, then you can use IVF as a tool and select embryos that have a lower chance of miscarriage. Other considerations I talk to patients about are ethical considerations. So if patients have a real ethical challenge with discarding any embryos and they want to give every embryo a chance, I say, gosh, let's talk about it. If you test your embryos and you have an embryo that is aneuploid, it's got an extra number 8 chromosome, I'm not going to want to transfer that embryo because I know not every test is perfect, but PGTA testing, they tell me, is 98% accurate. And if you get pregnant with that embryo, it's almost always going to be a miscarriage. And a miscarriage is not health neutral. You can have bleeding. It can take time to try again. It's emotionally challenging. So if you are going to do this testing, but then say, oh, well, could we transfer the aneuploid embryos later? I say, hey, let's really think about that. Maybe you just don't want to have that testing done because in my clinic, as of right now, we are not transferring aneuploid embryos because it's such a consideration of harm if someone were to have a miscarriage or have pregnancy complications because they transfer that abnormal embryo. So I think there's ethical things to think about for patients. And I say, listen, I've practiced for 20 years. I used to transfer embryos all the time without having this information. It might change the number of embryos we transfer. It might change the chances of success that I'm counseling you, whether you do PGTA testing or not. But let's think about the ethical implications of it and how you're going to feel having embryos the clinic is not going to transfer. Again, I think the studies that we went over really can isolate certain groups. Like as eggs age, it makes a lot more sense to do genetic screening of embryos as miscarriage rate increases, it's something to definitely consider and talk about. So I think about the indications for PGTA testing and talk about how that might interact with that patient's personal situation. So if my patients are young and they don't have a history of miscarriages, sometimes I'm talking about it because they might have a lot of embryos to choose from. So if someone has PCOS or they've got a high egg count, and I'm just thinking like, even if we stimulate you gently, you're going to have a lot of embryos to choose from. I do talk about PGTA testing as an embryo selection tool to decrease the number of transfers they might need in order to have a baby, even though the studies are kind of pros and cons. I've seen that in my own practice. And so I do offer it to people or think about it or talk about it. But I say, hey, there are some studies out there that say if you're under the age of 38, that it might not dramatically increase your chances of having a baby. And you just something to really think about. Another thing that I think about, I have a lot of patients that are doing fertility preservation. They, are partnered with somebody that's got sperm and eggs, and they're thinking, oh, should I freeze eggs or maybe I should freeze embryos? A lot of people are freezing embryos. And I say, if you do the genetic screening of the embryos now, you're going to have a much better feel about what you actually have frozen and waiting for you. So someone can have 5 embryos that look gorgeous under the microscope, but they come back to use them 5, 8 years later. And if they don't have a baby from those 5 embryos and we find out that they were genetically abnormal, it would be so much better to know that now in the present, because then you could maybe do another stimulation cycle and freeze normal or euploid embryos at this time, as opposed to finding out later, man, I wish I had more embryos or I had done that testing. So things that I think about when I'm counseling patients, it's their indication for doing IVF. I think about the age of the eggs. I think about the miscarriage history. I think about ethical considerations. And I think about, are they doing fertility preservation or not? Not everyone needs to do PGTA testing. There's so many pros and cons, and you should see the debates at our, medical conferences. There are some people in the field that think that every single embryo should be tested, no matter what indication. Like, we have this technology, why not use it? And there's other people that say, hey, no test is perfect. It might be 98% accurate, but it's not perfect. And what if there are embryos out there that we've tested as abnormal? We're only testing 5 to 10 of the cells. What if the rest of the embryo is actually normal and we're discarding embryos that would have actually turned into a live birth? And so there is no black and white in fertility. You'll hear me say that a lot, and you have to really think about your personal situation, about whether this testing is right for you or not. So another thing that I think of is if someone's young and the majority of the eggs are going to work just fine, plus they have diminished ovarian reserve. So someone's young, but their AMH is like 0.2. I say, you know what? You're only going to get 1 or 2 embryos. If this test isn't perfect, this PGTA testing, it's okay to consider just transferring. Just because we have access to this technology, it doesn't mean that you have to use it. So I do talk to patients about that. And the other group of patients is if someone is doing donor egg, I don't always recommend that they do the PGTA testing because those eggs are 25 years old. Most of them work just fine. So pros and cons, but if someone's young with diminished ovarian reserve or someone's transferring an embryo from a donor egg, I really, really, talk about pros and cons and really talk to the patient about their personal situation. Something to think about. Topic number 5, common misconceptions about PGTA testing. I can think of 3. Number 1, PGTA testing is 100% accurate. This is not true. The studies say it's most likely about 98% accurate, but no test is perfect. Think about it. We are testing 5 to 10 cells from an embryo that's about 100 cells. And if we are just testing cells that do not represent the rest of the cells in that embryo, then the information could be inaccurate. Misconception number 2, if I do PGTA testing, I am guaranteed to have a healthy baby. Oh my gosh, no. Their genetics are a funny thing. Pregnancy is a funny thing. You are just screening these embryos for chromosome balance, but birth defects or genetic issues can be multifactorial, and there's little genes or things that we just can't test for yet. So if you are pregnant and you have a screened embryo, the most likely outcome is you're going to have a beautiful, healthy baby, because that's just the most likely thing that's going to happen. But that PGTA testing is screening out embryos that would most likely not implant, or maybe it would result in a first trimester miscarriage, but it's not screening out health or guaranteeing a perfect baby. So it's really important that you understand that. Talk to your doctor about what you're actually testing for and what it means for you. Misconception number 3, doing PGA testing means I don't have to do prenatal testing. That's really not the case. So PGTA testing, again, 98% accurate. Most likely, if you're pregnant and the pregnancy is ongoing, everything's going to be fine and healthy. But you still should talk to your doctor about prenatal testing. Things like cell-free fetal DNA can be blood tests for the person who's pregnant and looking for fetal cells to screen for Down syndrome and other chromosome issues. You have the option of doing good in-depth ultrasounds to look for soft calls for genetic issues. And then you can still talk to your doctor about doing CVS testing or chorionic villus sampling or an amniocentesis. Those type of tests are much more accurate at diagnosing chromosome issues or issues within a pregnancy. Remember, when you're doing this PGTA testing, yes, we're screening for chromosome content, but we're just screening a few cells. And so when you're testing a pregnancy later, like for an amniocentesis, you're testing hundreds of cells. So it's much, much more accurate. So talk to your doctor about whether you should do prenatal testing or not, but don't assume that because you screened the embryo, that does not mean that you don't need to do any further testing. It's really a personal situation for you. Great for sticking around to the end of the video. I know this has been a really in-depth one. There's some questions I want to leave you to ask your doctor to help you figure out and how to make the decision if you're doing IVF, whether to do PGTA testing or not. So I can think of 3 questions. Number 1, do you recommend PGTA for me and my personal situation? Just ask the doctor, what do they think? Question number 2, what are the pros and cons for my personal situation? How is it helpful? When you look at my situation, what is it going to help with? What's good and bad? What are the risks and benefits? Think about it for you. And question number 3, what can I expect from the embryo report? If I do this genetic testing, am I going to learn the sex of the embryos, like the X and Y? Are you going to get a report on mosaic embryos? That is a whole nother topic, and I really will cover that soon. But mosaic embryos means that you tested 5 to 10 cells from that blastocyst, but they don't all have the same answer. Some of the cells are normal and some of the cells are abnormal. So you got to ask, is that a potential result from these embryos? And if so, what do we do with that in my personal situation? I know this was a really in-depth discussion, but it is so important. It is a big decision about whether to do PGTA testing or not. And you really need to understand the pros and cons, the risks and benefits. It can be an amazing technology, just like IVF is an amazing technology, but nothing is perfect, and you have to get counseling and figure out exactly what's right for you. Like this video if you learned something, comment with questions that you have. Be sure and subscribe to this channel to get my weekly videos all about reproductive health. And until next week, wishing you love, luck, and pineapples.